There she go.
There you go. What's going on, DocP?
Not much. I might have to break and have to come back. Because there's some stuff going on here. I might have to go and come back. And we have to restart it.
Okay.
So, but I at least wanted to start it. So, what's happening?
Nothing much. How's your day?
It's been all right. Can't complain too much.
Well, that's good.
It is what it is. What about yours?
I had a busy day, but a successful day. That's all I can ask for.
That's it. That's it.
All right.
So let's get started. I'll do as much as I can, and then and we just may have to. You busy
No.
tonight? All right. So I'm gonna do as much as I can, and then I'm gonna break, and then I'm gonna come back. So everybody that's on, hopefully they can hop back on. If not, we'll just record.
Okay.
I at least wanted to be on here on 7:30 since we put it out here at 7:30. So
right. Do you want to push it back?
I mean, we can at least start.
Okay.
And then if when I gotta go, then we'll just come back.
Okay. Sounds good to me.
All right.
Well, as everybody's trickling in, thank you all for joining. If this is your first time, welcome to the Visit DocP with me, as we like to call it, our monthly live where we answer Q&A after sharing my fibroid journey on social media. We've been doing this once a month to give people the opportunity to ask questions about my journey, to ask questions about maybe a journey they're going through themselves, and just opportunity to sometimes get free game. There's multiple ways that you can submit your question. So I have questions that people already submitted. There is a question bubble at the bottom of the screen where you can also click to submit a question, and then we screenshot those. So if we don't get to it tonight, we come back. And then most preferred is you can actually request to join the live yourself. And it's almost like you get a free consultation on the spot. So if you have your own personal question that you would like to ask tonight, please feel free to click the request to join, and we'll let you hop in the live and ask your question yourself. All right? All right, so I'm going to kick it off with something that was submitted already.
I need to talk about this tattoo real quick.
Oh, okay. You want to start with that?
Yeah, I don't have to. I mean, I don't care. But
we could start with that because that definitely.
Since you asked so many questions, you said you asked so many questions about it.
Yeah,
so I'll explain it real quick.
Yeah, so if you didn't see Dr. P's most recent post of his latest artwork, he has a new tattoo, and we're going to discuss what the symbolism of it is.
So I guess I'll just show it real quick. So that's it. And all the splendor.
But yeah, you have to. We probably have to see the post because you're not in.
You see the post. That's fine. But
it's all up the back of his head.
It's all up the back and all to the head. So, all right, real quick. So when I was a kid, I went to Saint Sabina Elementary and with Father Flager, and in that church there is a black Jesus coming out the heavens. With God standing in front of God's hands. When I was a kid, I said, I'm going to get that on my back. I'm going to do a back tattoo, and that's going to be the centerpiece. When I got adult, that was the start of my back tattoo. And it's a whole conglomerate of heaven, hell, it's all type of stuff. My entire back is filled with like the story of Jesus, heaven, and hell, XYZ. So from that, I'm a tattoo addict. So my thought process was to extend the tattoo and talk about heaven a little bit more, because there's such questions about heaven. Is there a true heaven? Like when you die, what happens? And in my thought process, I do believe in heaven, but I also believe that how you live your life on earth is already the start of heaven, and how you live your life after. So when I went to my artist, I basically was like, look, I want to extend my tattoo, but the concept that I want is eternal life through your mind, and how you live your life is how you will live in heaven. And an extension of my tattoo talking about heaven, that's where it came from. So I gave him the idea, and he nailed it. Like it's a concept. It's not something that like has a form, but it's my idea of heaven in my mind. And so all of those, like, oh, is it a vagina? No, I'm not a gynecologist that's going to tattoo a vagina and a uterus on my head. That's pretty creepy. So that is what it is. It is my concept of eternal life and heaven in my mind and how I live on earth. That is the concept of my tattoo.
So does your mom like it?
My mom don't like me getting tattoos, but she the problem though. My mama took, and she, I know I did. Yes, she did. My mama took me when I was 16 years old. She let me get a tattoo. She let me get this panther, big black panther on my arm. Had my signature in a basketball. Worst decision I ever made, but that's what started it. And she took me Wizard of Ink tattoo when I was 16 years old. And from there, every tattoo that I got before the age of 25, either got a tattoo removed or covered up. But that started the addiction. Like, so probably about 50, 60%, no, about 60, maybe 60 to 65% of my body is covered with tattoos. And I will probably keep going. I'm addicted.
And so how painful is the back of your head? Because it's not a lot of meat back there.
This shit hurts. It hurts. I've done a lot of ink, and my calf hurt. The back of the head hurt, and it's not the neck. None of the neck stuff hurts. It's really where the occipital bones are at, and because that's where you have nerves that come out here. So there's no numbing that. It's just straight nerves and bone. Like if you do tattooing over bone, it's painful, especially with bone and nerves. So right here, that sucked. But pain is love, and it's temporary, so I'm good. It's no problem.
That's true. You didn't never have to push out a baby, so.
Yeah, man. Look, if you had to sit through what I had to sit through with this, I'm like, man, it was.
You got a lot of faith in your patients now.
Yeah, it was tough. It was tough.
I think my most painful tattoo was the back of my leg, back of my thigh. And I said I wasn't getting no more after that and still did it again anyway.
Absolutely. I'm just an addict. I'm just going to keep going. I mean, like, it's just a way of life for me now. So it's like, whatever.
Yeah, I get it. Well, thank you for explaining that, because that definitely was the break of the internet this week.
And I am not explaining that no more. So if you don't see this, and anybody asks me, I'm just like, whatever.
Well, you're going to save it, right? So
I'm saving it. It's here. Like, so I've explained it. Nobody had to ask, oh, is it just the Van Gogh uterus? No, it's not. It's definitely not. It's just
a Van Gogh uterus.
It's not. I've heard some of everything. I was like,
that's
no.
Hilarious.
I was feeling it in my spirit. Like I'm always about being different. I've not seen anybody have like a tattoo that goes up like that. So that was my thought. I'm always unique, different.
And it's good to be unique, and it's good to be an individual.
Agreed.
I like the message that you posted with it as well.
Thank you.
All right. So one of the questions that just came up on the screen is, are you still on track to have your practice up and running by August?
Bam! Yes, I am. It might even be before then. So my final contract should be available to me tomorrow. We have been negotiating, and it should be here tomorrow, and I should have ink to paper within about a week or so. I already know where the practice is at. I just can't release it because, I just got to sign my name to the paper before I do that. But absolutely, by August, I won't say what day in August, I will have my practice. For everybody that had questions, no, I have not stopped operating. No, I have not stopped being a gynecologist. No, I've not stopped any of those things. Yes, I see out-of-state patients. I see in-state patients. It will be so much better once this happens, because I'll have 2 hospitals to operate out of, and I'll have a staff that actually listens to people and actually calls people. I will be working with residents, so you will be able to talk to a doctor like anytime you want. So it'll be so much better, and I'm gonna be operating more. So things will get better. I hope everybody just bear with me. I know I said like, oh, I'm not. This is my last surgery. It was my last surgery at that practice. So let me clarify. I am operating. I love surgery. I love helping people. I will have it. I promise you, as soon as ink is to paper, I will, for a week, I'm going to talk about my practice and where I'm at, where people can find me. In the meantime, you can always consult with me, virtual consult at docforthestreets.com. Like I do virtual consults, probably 10 to 15 a week still at this point. So if you cannot get in to see me, or if you're out of town, you can schedule up a virtual consultation. And if you are in town and you are needing surgery, or if I promise you surgery, just please be patient. That will be happening in August, September. And if you are waiting to get a consultation and you're close, I will be accepting all insurances, and you can come and see me. Like I said, probably I would estimate anywhere from like mid to end August, possibly early September, when I'll start seeing patients consistently.
All right. And will you continue to focus on gynecology or OB, or just
I will actually, which is the crazy thing now, because now I'll be starting to do some OB now, because since I'm working with residents, I will actually be seeing pregnant patients. Not a whole bunch, because that's not my big thing anymore, but I will be starting to see pregnant patients that can come see me. But my focus will be, primarily gynecology, but the clinic will also, see OB patients. So all my patients are like, I want you to deliver my baby. I want you to. So you will have the opportunity to come and do that now. I know I've been gone for a while with that, but I'll be back.
All right. And since you mentioned the consults, a question that had came in that was submitted, do you focus on gynecologic consults, or do you also offer weight loss consultations?
I do
Someone
both.
asked that.
I do both. Like, so gynecologic consults, weight loss, health, wellness, fitness, like all the stuff that, I'm not no big swole dude, but I'm very much so in shape, in tune with my body. I know how to put on weight. I know how to lose weight. I know how to, how to tailor your diet to do whatever you want to do, how to lose weight. So I offer that service as well with meal planning and prep and all that stuff. So, yes, I do all of it, all of the above.
All right. So if you're just joining, please, if you want to join the live, you can hit the button to request to join and ask your question. If you have a question you want to submit, please use the question box at the bottom of the screen to submit your questions, and we will get to them. All right, so one question in the chat. Are fibroids hormone dependent? Do they cause hormonal fluctuations?
Are fibroids hormone dependent? Yes and no. So yes, fibroids do grow with hormones, right? So they are dependent on hormones, but they're not, they don't make hormones fluctuate, right? So we know that there are medications like Lupron, for instance, and people ask me about Lupron all the time. So Lupron is a medication that basically puts you into a pseudo menopause. It cuts off your ovarian supply. When you're on that medication, the fibroids do shrink. And people are like, well, why can't you just put people on Lupron? Lupron has big side effects. Number one, you're pretty much putting somebody in menopause temporarily. And number two, you can't use it for an extended period of time. You can only use it for 12 to 18 months. So it's really no long-term benefit of using it. So it's not, the risk and the benefits don't match up. Yes, in answer to the question, they do respond to hormones. Why some women will have 2 centimeter fibroids and have 2 centimeter fibroids for 20 years, with 2 centimeters like that. Why they'll have these for 20 years and your body's producing hormone, and some women will have gigantual fibroids that'll grow very quickly. We don't know the answer to that. But as far as them messing with your hormones levels, making you more estrogen dependent, progesterone levels elevated, it doesn't do that so much, but it does utilize hormones in order to grow.
All right. Next question. I had a hysterectomy 25 years ago. I am now experiencing painful sex and lower back pain. What products or medicines can women use safely to alleviate pain?
So, number one, pain is a very difficult thing. You have to assess the pain. So if the pain is from menopause or, vaginal atrophy, when there's a lack of blood flow to the vagina, if you're having pain because of that, there are treatment options for that. If the pain is from a structural cause, whether it be fibrotic tissue at the vaginal cuff, meaning like scar tissue at your vaginal cuff, or it's myofascial pain, meaning like the layer of skin that's up underneath the skin in your belly. If that's causing a tensile pain, there are multitudes of things that can cause dyspareunia, which is pain with sex. There are multitudes of things that can cause it, but you have to pinpoint like why you're having the pain first. And then you can come with treatment options, because I can give you all types of treatment options, but if they're not assessed, or if the treatment options are not for the right diagnosis, they're not going to work. So that's the first and foremost thing, is to get the proper diagnosis.
All right. Next question. Hi, DocP. I appreciate you always sharing history on your page about how sometimes we are not trusting of doctors. I think a common practice in our community is sharing medicine to avoid a doctor visit. I myself have been guilty of using someone else's antibiotics to treat BV, B as in boy, V as in vagina. I assumed I had and later found out I didn't even have BV. Can you explain the dangers in this? And are there any medicines in particular that are even more dangerous to share that are absolutely off limits?
Absolutely. Excellent question. That's a really good question, actually. So as far as, and this is a problem that I see all the time about women that just really want antibiotics to treat what you presume as BV. And it's, the dangers of just taking antibiotics for non-infections is resistance, because just think about it. Your body gets resistant to things, right? So we use antibiotics to kill bacteria. If you consistently take antibiotics, your body or the bacteria can form a resistance to the particular antibiotic that you're utilizing. So that's the thing. If somebody's continuously taking flagyl and doesn't really have a BV infection, when they actually do get BV, it may be resistant to that flagyl, and then now we have a true problem in treating it. So that's problem number one, in just taking antibiotics. Problem number two is that, we worry about side effects with everything else. Like people worry about side effects with COVID. People worry about side effects in the food we eat, or some of the other medications. You think antibiotics are just harmless? They're not. Antibiotics have side effects too. So you don't take medications just because you think you should take them. You need to have a diagnosis first, and then understanding that all bacteria are not the same, right? People think they could take penicillin for everything and it's going to fix everything, right? Or people think they take amoxicillin and it's going to fix it, right? But realize that if you have an actual virus, like for instance, like I see people, just write me a Z-Pack, or just take penicillin for it. If you have a virus and you take an antibiotic, you're going to make the virus worse. So you're going to get sicker before you get better, right? So like antibiotics do not fix everything. Getting a proper diagnosis and then taking the appropriate antibiotics, if you need to take them, is very key. And understanding if there is an infection, do not treat yourself, right? I'm not a lawyer, so I don't start giving legal advice. You're not a doctor, so don't start diagnosing yourself and say, I'm just going to take antibiotics when I think I got BV, right? It's just, it will do much more harm for you than good, because again, I see women all the time. I got BV. Give me flagyl. There's a risk to that. Again, flagyl has side effects. And again, if you continue to take flagyl and you don't have BV, you can form a resistance. So if you actually do get it, it's a problem.
That's excellent. All right. Next question. I am a woman in my 30s that has been abstinent. I spent my 20s being serious about my education and my career. At this age, I'm ready to settle down, but I don't want painful sex. Do you recommend getting my hymen surgically removed?
No, I don't. I don't think so wait a minute. So she said she's virginal completely.
Well, right. It says abstinent, so I thought that too, but so I was wondering, do you even have one? But I'm not sure.
So abstinence means that she's had sex and then decided to not
To
have
stop.
sex
That's what I
again.
thought too. But
So
I'm not. I'm not.
if that's the case, then you don't have a hymen anymore. Hymen is done. But if you never had sex before, um, can you get your hymen surgically removed? Yes, but remember, surgery is painful too, right? So you avoiding pain with sex, um, to have surgery to avoid that. I wouldn't necessarily recommend it. You got risk of anesthesia. You also have post-operative pain. There's no surgery that's not painful at all. So I would just say take gentle care. Talk to your partner. Be extremely gentle when you decide to have sex. And it doesn't have to be painful if with conversation and understanding of anatomy. First time intercourse or intercourse after a long period of time does not have to be painful. I would recommend using lubricants, right? Is In specific, um, silicone-based lubricant, which is extremely slick and not messy, which will make it less painful as well. But just communication, use lubricants. I would not recommend doing surgery to avoid painful sex.
All right. What is the best way to lower blood pressure? It seems like foods that are recommended are always changing, and then the medicines always change too, like they only prescribe what they want to sell at the moment.
Great question. First and foremost, healthy diet and exercise is the number one non-pharmaceutical thing that you can do for your blood pressure, right? So, eating a healthy diet that is low in fat, low in cholesterol, um, low in carbohydrates, um, non-fatty, with a lot of water, and not sugary drinks, but water. That helps with your blood pressure, and also low salt, right? So low salt diet with a lot of water will help because salt is a solute, which if you don't have a lot of water in your body and you have high levels of salt, you cause vasoconstriction or the blood vessels to clamp down, which can increase your blood pressure. So understanding the diet aspect of it helps. Exercise also helps because exercise is basically exercise for your heart, which is the most important muscle in your body. So the less strain that you put on the heart, the less your heart has to work and your blood pressure will typically go down. With that being said, understand that benign essential hypertension is a real thing. I have patients that are normal weight, work out, drink water, and have hypertension, right? So people are confused as if you just live right and do this right things, you won't get hypertension. That's not true. Some people have inherent hypertension. And if that is the case, that's where medications come in. People get the false perception that doctors like myself are just pushing medications. I'm not saying some of them don't, but real doctors, true doctors that really care about people are not just pushing medications. They're preaching healthy lifestyle first. And when healthy lifestyle is optimized, but there are still diseases, just like diabetes. Some people have inherent diabetes. Type 1 diabetes is something that you can't exercise away, something that you're born with. So when people have diseases, medications are needed. For our people, there are medications like ACE inhibitors, beta blockers. There are particular medications depending on your who you are, and what other health ailments that you have. There are particular medications that are better for you, better for our culture and our people. So you really need to not only do research and educate about those things, which information is readily available. Talk to your doctor about why are you choosing this medication, why this particular medication, and have them break it down. If it doesn't sound right, and
Get
you
your
can ask
purse.
straight up. Yeah, you can ask straight up, like, do you have an interest in this particular medication? Like, ask them. Like, if a doctor is doing what they should be doing and they care about you, then they'll have these conversations without, and they are only offended. Like, oh, are you asking? We gotta go. It's because of a patient asking me specific why I like this
You
medication
echoing.
I prescribe. Breaking.
Echoing. It's an echo.
Maybe acting stupid. Can you hear me?
Okay. Yep.
So if the doctor is asking, if you're talking to your doctor and they're not receptive of you as a patient, and understanding that you are a patient that is concerned about their body, has rights, that want a relationship, right? Because a doctor-patient interaction should be a relationship. It should be a conversation. Anytime I talk to my patients, I am not pushing things on you. You know, it is a complete conversation. When I give options, I let you know, I feel this particular way about this option. I don't think that you should do this option, but I'm not going to take that option away. Just like somebody just said, UFE, I hate it. Okay. So I just read that. And I was actually just thinking about that when I said that. That's crazy that just happened. But I don't like UFEs. I don't agree with them. I don't think they work well. I'm just not a proponent. However, my governing body, American College of Obstetrics and Gynecology, says that it is a viable option. There are studies that says that it has worked for people. In my particular experience, I have not had great experience with all of the experience I've had with fibroids. UFEs have been horrible. I have pictures of women that I have operated on that show that UFEs have done way more harm than good. Yet and still, and I wouldn't tell my mama, my aunt, nobody in my family would I recommend doing a UFE. However, when a patient comes and sit in front of me, I'm gonna say, look, you have a UFE as an option. I don't want it, but it's your choice. I can't take that choice away from you. And if your doctor is taking choices away from you, then you need to find another physician. Our job is to give you the options and to give you recommendations on what's going on with you. But at the end of the day, it's your options. UFEs, real quick, just don't work very well, right? So they cause ischemic necrosis. They cut off the blood supply to fibroids. If you sit on your hands right now and put them up under your butt, if you do it for a long period of time, your hands will start tingling, and you do like this, and it tingle, 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 tingle. But eventually that tingle will go away because the blood flow returns to your hands. If you do that to the fibroids, which is exactly what you're doing, you're going to cause pain, but you can't shake your fibroids or shake your uterus to get the blood supply back. The blood supply is just gone. So I've had women that it's caused chronic pain. It hasn't worked. It's difficult to perform further surgeries. There's a host of different reasons why I don't agree with UFE. And if you're saying, yeah, your doctor, and I really am not talking about nobody. I try not to, but if your doctor is pushing you to get a UFE, it's typically because they are not very skilled surgically to do some of the other surgeries that are out there. And that's something that, is another option that they don't have to really worry about if they're skilled or not. It's something that they refer you to an interventional radiologist and be done. But as someone that experiences it, and I'm going to a whole nother topic, but as somebody that experiences UFEs all the time, I wouldn't recommend it to anyone in my family at all. And so when I'm talking to you, that's how I'm talking to you. I'm talking to you like my sister, like my mama. I'm not going to tell my mama to do it. I'm not going to tell you to do it.
Yep. I can vouch for that. All right. Question in the chat. Is there medication for mood swings, emotional side effects of your monthly menstrual period?
There are, right? So, what she's talking about is premenstrual syndrome, and yes, it is a real thing. Estrogen and progesterone, they do impact your hormone levels and your mood. So with that being said, I have women that have extremely bad PMS where they have cramping pain, and that's another thing. Just think about, like, it may not even also always be about depression or anxiety. It may be that you're going through so much pain, bleeding, the fact that you can't do your normal your normal things of life, and it causes you to be depressed, right? And it'll cause some depression. And typically, the first thing you do is try to treat the underlying problem. So if the underlying problem is heavy cramping, heavy bleeding, let's treat that first to see if the mood improves. If the mood doesn't improve with that, then there are things like SSRIs or selective serotonin reuptake inhibitors, which are antidepressants that are not only work for antidepression, but they also work for, or they are indicated for as treatments for PMS. So yes, so have that conversation with your doctor. It's a big algorithm of how to treat PMS symptoms. You start off conservatively, ibuprofen, scheduled 2 days before, not when you feel the pain, but before. So 2 days, 2 days before, 800 milligrams, every 8 hours to stop the prostaglandin release, to stop the pain, to stop the cramp, or decrease the pain, decrease the cramp, and decrease the bleeding. Start with that, and if it's persistent with that, then talk about possible SSRI therapy.
All right, if you're just joining, you're more than welcome to join the live. You can hit the request to join the live and ask your question yourself. Thank you for those who are submitting them in the chat box at the bottom. Yeah. You can also use the question mark with the circle around it to add your questions. Go ahead,
if you want to hop on the live, you can to ask a question. Feel free. And I saw somebody asking about eSure. I don't think it's too late for those class action lawsuits. I think, I think you still can do that. Hell, if they could sue us until 18 years old and baby's 18 years old, I'm sure you have time to sue for eSure.
Yeah, especially in Illinois. All right.
No, I don't recommend that women should just get eSure removed if you're not having problems. If you're not having problems, just leave it alone. If you are having problems, then have a discussion. But if you have coils from eSure there and you're not having any issues, just let it be.
All right. Next question. I am considering having a hysterectomy. Are there any hormone supplements that I will need post-op?
No. So plain and simple, just ask your doctor. I don't know how old you are, what your situation are, but generally speaking, you do not need hormones just knee jerk after hysterectomy. So remember, your uterus does not control hormone level. It's your ovaries. So if you get a hysterectomy and you keep your ovaries, you don't have any changes in your hormone production. Right? Am I correct in saying that?
Yes, you are very accurate.
All right. So she is a living witness. She had a hysterectomy. She has her ovaries. She is not experiencing menopausal symptoms. There's no need for me as her physician to give her hormone replacement medication. If you do have your ovaries removed, and for whatever reason they're removed early, then there's a discussion about possible hormone replacement just for that. But you don't just knee-jerk start giving hormone replacement for menopausal symptoms, right? Even when you're close to menopause, you don't just give hormone replacement therapy. So for your question, if you are of menopausal age and you're getting a hysterectomy, and you're whether you're keeping your ovaries or not, you do not need hormone replacement therapy. If you are premenopausal and you are getting a hysterectomy and you're keeping your ovaries, you do not need hormone replacement therapy. If you're premenopausal, like 45 and below, and for whatever reason they're removing your ovaries, which they should not, but if they are for whatever reason, then yes, the discussion for hormone replacement can be had. It should be had because your ovaries, when you are premenopausal, are producing hormone that are responsible for your heart health and your bone health, right? So women that get their ovaries removed early, too early, there are increased risk of osteoporosis, increased risk of heart disease later in life, and so with this in mind, giving them hormone replacement back is indicated.
All right, and since you brought up what I had removed, I did have a question for me, and I got this a couple times this month. So Doc P mentioned that you had, this is for me, Doc P mentioned that you had your uterus removed as well as your cervix. Does that cause any changes in sexual activity, orgasms, or being able to create wetness without lube? Thanks for your help. So I got that quite a few times this month. I did not have any issues with orgasms. They're actually better because I used to get really, really bad cramping after orgasms, and I don't have any of that anymore. I don't have any issues with wetness before, so I don't, it's like back to my normal, like nothing changed about my vagina removing the uterus and the cervix. So if you didn't need lube prior, I don't think you will need to add lube. If you are already using lube, I can't, maybe you will still have to use it. But nothing changed physically about my vaginal area just because I removed my cervix and my uterus. Nothing at all. And I do have my ovaries. So
everything, and I co-sign everything she said. It's not, there's no reason why removing your cervix or your uterus, should you have any change in sensation or sexual pleasure. Like, I've done this thousands of times, and I haven't had any woman that came back and said, "Oh my God, you killed me!" Like, I'm not enjoying sex anymore. I haven't had that. In the contrary, women with fibroids, with those issues, are not having pleasurable sex with it. So when you take it away, the sex could be pleasurable because they're not having pain, and the other issues, those are alleviated, or bleeding all the damn time, which ruins sex and stuff too. So when you take those things away, sex actually becomes more pleasurable.
And they also said, is it longer to orgasm or anything? The orgasm does not change. It doesn't take longer. It's not shorter. It's the same. It just no more cramping afterwards, which was terrible. So if that's your hesitation, don't let it be. All right. I'm a new follower, so I apologize if this was discussed in advance. How big should a woman's uterus be? You mentioned Cola's uterus was bigger than your hand. Should we assume that that's not the right size? Were fibroids still in her uterus, or did you have to take them all out first and then do the hysterectomy? And by the way, her journey left me speechless.
So first and foremost, Cola's uterus was not as big as my hand. It was big as my computer.
You know what?
This right here, this was Cola's uterus right here with a fibroids right there. So that's different. But all kidding aside, so the uterus size varies with age. So the older you get, it gets a little bit larger, and then as you near menopause, it gets smaller, and as you pass menopause, it gets even more smaller. So the normal size kind of varies per patient because it also depends on how many children you've had. So women that are multiparous, or even grand multiparous, meaning more than 5 babies, they're going to have a naturally larger uterus than someone that has never had a baby before. So normal is relative. As far as removal or hysterectomy is concerned, to keep things in a minimally invasive perspective, meaning very small incisions. So as big as Cola's surgery, big as Cola's uterus and her fibroids were, I was still able to remove it with incisions that look like this. To be able to do that, I had to debulk or remove some of those fibroids off inside of her belly, and then once I disconnected everything, for lack of a better term, and controlled the blood supply, just remove everything through her vagina, piece by piece by piece by piece by piece. And that's really how you keep things laparoscopically, or with small incisions. When you open the belly, right, with the big incision, then you can just take it all out. But that's more pain, longer recovery time, higher risk of infection, typically more bleeding. So it's an advantage to be able to do it laparoscopically. And again, I contend that it really doesn't get much larger than Cola's. So with that being said, I think that everybody at least has the opportunity to have laparoscopic surgery. for hysterectomy, not myomectomy. That's different. But for hysterectomy, everybody has an opportunity. Not to say that everybody can be done, because it can get bigger than hers, but usually it doesn't get much bigger than that. And if it stays to that point, you should be able to at least have the option to do it laparoscopically, which is much better for people. Did she ask something else that I missed?
No, I think that was it. She just said, oh, she said, did you take them out before you pulled everything out? But you just said piece by piece.
Yeah,
So
I couldn't take them. Yeah, I couldn't take them out before I took it, because the vagina is attached to the cervix, which is then connected to the uterus, and then the fibroids are connected to the uterus. To get everything out of the vagina, you actually have to disconnect or get all of the blood supply of the uterus and the cervix down, and then the cervix sits at the top of the vagina, and then you have to cookie cutter the cervix out, which makes this hole at the top of the vagina, and then everything comes through this hole. So vagina, cervix, cervix, uterus, fibroids, they all come through this hole. But to get that hole, you actually have to get all of the blood supply and then cut around the cervix, which is at the top of the vagina, then remove all of those pieces through that hole.
All right. And follow up, does that impact elasticity? So I have no reason to believe that my walls change from removing everything out of my vaginal that way. Sex doesn't feel different to me. So I have no reason to believe that. I'm not the guy, but I don't think, I think it's fine.
The vagina is very resilient. Realize that, women have 8, 9, 10-pound babies, and vagina comes back. So removing the uterus or what have you, even as big as her uterus was with the fibroids, it wasn't bigger than some of my, regular babies. It was 6 pounds, 7 ounces. So I delivered babies 7 pounds, 8 pounds, 9 pounds. So, so having that being said, no, it doesn't destroy the elasticity.
All right. Well, good questions though.
So real quick, this is a good question. So 2 quick questions. So at what point or size is laparoscopic myomectomy no longer an option? So I used to perform I used to perform laparoscopic myomectomies all the time. What I found with my experience is that the patients that I performed laparoscopic myomectomies had a higher incidence of fibroid return. And the reason that is because if you do not get all of the fibroids, they have the ability and the propensity to get larger and to grow. And the problem with laparoscopic myomectomy, I have a couple of different problems with it. Number one is that you lose palpation or your tactile sensation to be able to feel the uterus. So you can only get what you see. So if I can't see it and I got like a pea-sized, marble-sized fibroid that's in the muscle of the uterus, there's no way I can see it. So I'm just only getting what I can see, preparing the uterus, and I leave that. And if I leave that, then it can grow to be bigger. So the second problem that I have is that when you do major surgery on the uterus, when you take these fibroids out laparoscopically, you have to have a C-section anyway. So it doesn't really make much sense to have a longer procedure with the laparoscopic surgery and then end up having to have a C-section. My goal and what I do is to perfect a surgery in which I'm using very small incisions for an open myomectomy, removing those fibroids, and then using that same incision or maybe even a slightly larger incision for a C-section in the future. So me personally, I don't do many laparoscopic myomectomies anymore unless for very specific circumstances, like if it's known that a patient has a single fibroid, they're looking for fertility, and they just really need to remove that particular fibroid, and it needs to be done quick or what have you. Like, it's a very few instances, but even with that being said, I encourage patients to get open myomectomies, but with the caveat, absolutely no vertical incision and using the very smallest incision that you possibly can. I don't make big incisions, small incisions in the hairline, be able to use those for C-sections in the future. The other question that was, where do the ovaries attach when the uterus is removed? Very, very quickly. So the ovaries, have pedicles or large blood supplies. It's a big ligament called the Infinibilo pelvic ligament that comes down. Say that 8 times fast. Infinibilo. So
Yeah.
it's an infundibulous pelvic
No,
ligament
just
that to the ovary, and this is where 90% of the blood supply comes from this ligament, right? The other 10% comes from its attachment to the uterus. So when you clamp it and cut the ovaries off of the uterus, they're still attached to their major blood supply, which is the infundibulopelvic ligaments that travel on the lateral or the sides of the abdomen or the belly. So that's kind of their suspensory ligaments, or how they hang. They don't just like jiggle around like marbles at the floor. They have their own ligaments, and they kind of stay in their pockets with their ligaments. Whew. Okay, go ahead.
No, good stuff. How much shrinkage do you see with the excessive procedure?
So, and I just had this conversation when I was teaching it day before yesterday. So excessive, it can shrink the fibroid up to 45%. But remember I said up to 45%. The beauty of excessa, or the success of excessa, is not the actual shrinking in the size. It's shrinking in the volume, right? So excessa is utilized to change the volumes, not so much the size. What do I mean by volume? It's like taking a baseball and turning it into a marshmallow, right? So the symptoms from fibroids, like pain with sex, cramping, frequency in urination, any other, like I'm drawing a blank on a lot of other symptoms, but any of the symptoms which we call bulk symptoms are typically because the fibroid is so hard, right? It's large, but it's hard. So your uterus is clamping down over a very hard inanimate object, right? When you soften that object, it becomes easier for things that are pushing up against it. They're pushing up against something soft as opposed to something that's hard. Your uterus is squeezing around something that's softer as opposed to something that's being harder. So the beauty of it is not going from 8 centimeters to 4 centimeters. The beauty of it is going from this big, hard softball to, a big marshmallow, right? And that's what we want. We want the volume of it to change, and that's why excess is so beneficial. People, and I tell physicians this all the time, and patients as well, you don't get repeat ultrasounds after excess because your fibroid is still there, right? And you don't freak out. It's like, oh, it's only 6 centimeters. It was 7 centimeters before, and now it's only 5 or 6, and it didn't get the shrinkage that I want. That's not the point. It's the volume of it. And 2, are your symptoms better? If your symptoms are better, then it worked. We don't care about the size per se. We care about how the fibroid is impacting the patient.
All right. Another question that's submitted in the chat box tonight. Can balancing your hormones help with weight loss?
Yes and no. Weight loss or weight gain is not always a product of hormone imbalance. A lot of times it is eating imbalance, right? So addressing our diet and exercise first is paramount in dealing with weight gain now, or weight loss rather. But understanding if the weight gain is from hormone imbalance and addressing that is also key. So getting a full laboratory workup, if you are gaining weight excessively, or if you have gained a significant amount of weight that doesn't make any sense to you, going to your doctor and getting a full workup of labs is important. Most notably, your thyroid hormone. So your thyroid hormone, when women are hypothyroid, they have a propensity to have excessive weight gain. And that's because their thyroid levels are completely off whack. And so if that's the case, if your weight gain is because you're hypothyroid, then correcting the hypothyroid will go tenfold in your weight gain. So understanding if there's a hormone imbalance first, and then addressing it if so. But if the hormones are normal and everything else is normal, now we talk about diet and exercise.
All right. So if you're still just joining, you're still welcome to join the live yourself. You can send a request directly to Dr. P to join the live, and you can pop in to ask your question.
Everybody acting scared and nervous.
Yeah, we're in a safe space.
Safe space.
All right.
All right.
I'm sorry. Say you was about to say
No,
something.
we'll keep going.
Okay. How you
Nobody
doing on
on
time?
live.
How are you doing on time?
I'm good. They ain't called me yet, so we good.
Okay. Okay. All right. What is the difference between an MD doctor and a DO doctor? Like, I know the textbook answer, but could you please break it down for regular folk? Like, when I'm choosing a provider, what should it mean to me?
Awesome question. Very, very good question. So the difference between an MD and a DO is not very significant. So an MD uh, is a allopathic doctor, for a technical term. A DO is a osteopathic doctor, right? Doctor in osteopathic medicine. Both of us, both doctors have to go to a accredited medical school for 4 years. Both doctors have to go into residency or perform a residency specific for their field. So I have a very close friend that is a DO that was in my residency program. He did his 4 years of his osteopathic uh, medical school, and then he did residency right behind me in my residency. So is from that standpoint is not um, much of a difference. The difference between a osteopathic and an allopathic medical school is that the osteopathic believe more in some of the um, holistic medications, herbal medications, and like some of like manipulation, chiropractic things, like some of um, the non-traditional medicines. Like they learn more about those. So that's really the major difference that I know of. I've never been to. I'm an allopathic doctor, so I can't speak entirely on osteopathic medical school. It's just from what I know from my friends that are DOs. But when you're looking for a doctor, and you're like, I don't want to go to him because he's a DO, don't look at it like that. They went to medical school. They had training, but treat them the same way you would an MD, but at the same token, put them all in the spectrum of are they a good doctor or not? Because you got good DOs and bad DOs. You got good MDs, you got bad MDs. From a knowledge level and training level, we typically have to do the same things, but that doesn't make us all equal. So just, don't discriminate for a provider because of that particular title, but discriminate definitely if they're not good physicians or they're not doing the things that you need them to do.
All right. Another question submitted in the chat box. I have a fibroid located behind my uterus. Does it need to be removed? I spoke to a surgeon and he suggested a laparoscopic myomectomy.
Plain and simple. Is it causing you pain, or is it causing you any other issues or to your quality of life? If it's sitting there and your quality of life is you're not having, super heavy periods, you're not, having pain with sex, you're not having, significant cramping, like if it's not causing you problems, leave it alone. If it's causing you significant problems, then see if, number one, your doctor should be able to see whether or not those problems are caused by that fibroid. Typically, if it's not very large, then it should not be. But again, good doctors, bad doctors. A good doctor will be able to tell you if that fibroid is causing you to have the symptoms that you're having. A bad doctor will tell you, hey, you just need to deal with it. You got a fibroid, deal with it no matter what else is going on. Because people have fibroids and are told that they are causing the problems that they're having. And a lot of the times they're not. Just like I have, I see doctors all the time say, well, yeah, if I treat your fibroids, like your bleeding is going to get better. Well, it's not true, because bleeding can be caused by a multitude of things, not just fibroids. So if a patient, if they're promising you like, oh yeah, just take your fibroids, your bleeding is going to get 100% better, then have your antennas up, But in a nutshell, to your answer to your question, like fibroids don't have to be dealt with unless they're causing significant problems, i.e. infertility, i.e. pain, those types of things. If they're causing those types of things, then you could look for treatment options. And they don't necessarily have to be removed. You have Excessa. You have other options for actually treating them and maybe not removing them that are less invasive. So explore your options and understand your options and ask plenty of questions. If your doctor is not okay with you asking questions or does not take the time to explain things thoroughly to you, gotta find a new one.
Get your purse.
Absolutely.
All right. A guy PA mentioned a mini tummy tuck during a robotic hysterectomy. Is that a real thing?
I have to see that. I mean, you could. I wouldn't speak disparagingly about anything, but that's tough. If you're doing a robotic hysterectomy, that means you're doing small incisions in the upper part of the belly. If you're doing a tummy tuck, then that means you're cutting out large areas of skin in the bottom part. So that's another part of the procedure. Can you do a tummy tuck with that robotic hysterectomy? You can, but it's definitely not part of the surgery. So that's just an addition to the surgery. But then I would also, that's kind of alleviating what the surgery is, because if they're doing a mini tummy tuck, then I wouldn't necessarily do a laparoscopic surgery. You know, it just kind of takes the point of laparoscopic surgery away if you're making these big incisions in the skin. So I would have to see what their philosophy are and what they're actually doing to comment on that one. That's one I got to kind of plead the fifth on. It's just not customary to do that, put it that way.
All right.
Call them wrong. I won't say that they're wrong or that there's the quacks or anything. I won't say any of that. I would just say that I would actually have to talk to them and see what they're doing to actually comment on it, because it's some conflicting things there, and I would need more information from them to make a accurate assessment or an opinion about what's happening.
All right. Another submitted question. Do you perform FTM hysterectomy gender affirming for non-binary or trans individuals?
What does the FTM stand for?
Yeah, I just reading what they sent me.
So I don't know the acronym FTM. I am never afraid to say when I don't know something. I just don't know. I don't know what the acronym FTM stands for. But as far as hysterectomies for a trans female, a trans male, yes, I would, absolutely. It's a decision. It's your body, your choice for if you want to do that or not. It's not my decision, or it's not my right to be able to tell you that you can't have it. So yes, I do perform hysterectomies for those patients. Give me one second.
All right. All right. So if you're just joining us, you still have the opportunity to join the live in person if you want to be featured in the live yourself. Thank you for the answer to the acronym. When DocP comes back, I'll make sure we say that. If you're just joining, feel free to put your questions in the chat bubble, but also feel free to send a request if you would like to join in person and be able to ask your question yourself. All right, so since DocP is taking a call, I will answer one of the questions that actually is submitted for me. So Cola, thank you for sharing your journey and your fears. Was your hesitation to have a male gynecologist because they don't know what it's like to be a woman? That's an excellent question. So I actually personally never really thought about if the doctor would know what it's like to be a man or what it's like to be a girl. If you've watched my journey, so I've just had a funny relationship with the gynecology profession in general. So I graduated high school at 16 years old and went to college at 16. So prior going to college, I wanted to get on birth control. I tried to talk to my dad about, I was raised religious. You're not supposed to have sex before marriage. So I tried to have that conversation like, Dad, I think if you're in love, you don't have to wait. And he was real quiet. So I had a cool auntie that I was like, I'm gonna talk to her, because if my dad acted like that, I know what my mom's gonna say. So I went to my aunt, and she was like, oh, I definitely could take you to a gynecologist. So fast forward to my first gynecologic appointment was with a female. Again, I'm 16 years old. So when I tell her that I want to get on birth control, she says I have to get a pap smear. This woman cranked me open so wide with the whatever that tool is that they use, speculum. And I was just like, I'm 16. And I'm just like, you have to open it that far for a Q-tip? Like, I was just devastated. Like, I was just like really traumatized, if that's the better word. So that was the first experience with a gynecologist. So I kind of more frowned at gynecologists in general after that visit. So I'm still 16. I'm in college. I have one lecture hall class. Even though it's 500 people, the teacher forces us to sit in assigned seats. So I've only been sitting next to the same person for about a week. And she's one of the students is crying really, really bad. So when I look over, I'm like, are you okay? You need some tissue, whatever. And she was like, I can't believe it. I just slept with my gynecologist. And I was like, wait, what? And then she was like, yeah, I can't, he didn't hurt me. I just can't believe it happened. And I was like, so why are you crying though? And then she was just like, I'm just so flustered. I can't believe it. And she was like, well, I go to him all the time anyway, because I have trichomonas. I'm 16, so I have no idea what that means, but I work at the medical bookstore at my college. So I look it up. So now I'm like, okay, I went to a female gynecologist and she opened me for dear life for a Q-tip. And then a male gynecologist might sleep with you if you go. But again, this is a 16-year-old mindset. So at that point, I never saw a gynecologist again. I completely went to family practice doctors. The only time I ever saw a gynecologist was to deliver my 2 children, and they're back to back. So it just so happened I saw the same doctor for 2 years straight. But as soon as I had my kids, I went right back to family practice doctors. And then I did try to go back to my gynecologist to get my tubes tied. She wouldn't do it. So I did have to find my own gynecologist that would do it. But other than that, I would not see a gynecologist. So it was less about me thinking Dr. P didn't know how to be feel what it's like to be a woman. Then when I was 16, I had 2 traumatic things happen to me associated with gynecologists. So I just didn't see gynecologists anyway. If you did watch my journey, you will notice that I said my primary doctor is a family practice now. So I literally have not in my whole adult life really ever dealt with gynecologists in general. I was just afraid of them at period. And then I read medical apartheid. So I was just like, they monsters. Like I was never going to see a gynecologist ever. So it was like much later in life. But I'm just saying, like, I just was like, not into gynecology. The lady who delivered my babies was wonderful though. I was looking for a Black female that did residency at Cook County, and she fit the criteria, and she was wonderful. It's just that I just didn't like gynecologists because of what happened to me when I was 16. So that was really, it had nothing to do with that. I actually watched him on social media for about a year, so I could see that he always talked about treating his patients like he would a family member. And that made way more sense to me than does he know how to feel like a woman, or does he know what it's like to be a woman?
Oh, that was the question. Like, can a man?
Yeah, somebody asked, was my hesitation or my fear because you don't know what it's like to be a woman? And I got asked that several times this month, so I thought I'd bring it up.
My question would that be is, would I tell a man to not go to a woman urologist because she doesn't know what it's like to be a man?
Yeah, I like I said, that really honestly truly didn't cross my mind. And again, I was 16, so now I don't think that all male gynecologists sleep with their patients or not. But I was 16 and I had just got violated by one woman, and then now this girl crying. I'm just like, oh, I don't like gynecologists. I'm gonna leave them doctors alone. They too invasive. So again, I was 16, so that just was my impression from an early age that gynecologist wasn't for me. But I'm better now, and Dr. P is my gynecologist, and he definitely will see me on a regular basis. I am not only dealing with family practice. because I like that he has a different opinion on things than she does, on certain things. All right, I just answered a question since you were busy.
You did excellent.
I was like, let me find one that was for me. All right. This is a sexual health question. So can you explain is squirt pee? This always comes up, but I never get a real answer to this question.
Oh, Jesus.
Sorry.
Okay. All right. I had a whole thing on this. Like, if y'all scroll back, I talked about it in a post. All right. Nutshell, real quick. Pay attention. All right, because I know somebody is going to say, oh, he said it's pee. No, I didn't. I want you to very, very, very closely listen to me. Okay? When a man ejaculates, right, a man ejaculates, there's an entire system. There's something called a Cremasteric Reflex where the testicles ascend. There's fluid that is produced, semen, or sperm that's produced in the testicles. It goes up to the prostate gland and it has this whole like fructose and stuff added to it, and then it expels out, right, out of a hole, the urethra, right? That is ejaculation. So the problem that I have with squirting is that we equate squirting with ejaculation, and they're two totally different things. Women do not ejaculate in that sense, because an ejaculation is a spontaneous thing that happens that's also associated with orgasms. For women, there are 3 holes, right? Men have 2. They have the anus and they have the urethra. Women have the anus, they have the vagina, and they have the urethra as well, right? The only thing that comes out of the urethra for women is urine. It's attached to the bladder. So there's no fluid that is coming out of the bladder, ejaculating out of the urethra, analogous to a man. We already know what comes out the anus. That leaves the vagina, right? In the vagina is basically a blind pouch. There are a couple of glands that are in there, but believe it or not, those glands are not responsible. Well, they're not significantly responsible for lubrication. So you have the Skene's gland, the Bartholin's gland. They are responsible for like maybe 10% of vaginal lubrication. The majority of the lubrication for the vagina actually comes from blood vessels. So when women get relaxed, the blood vessels expand or they dilate, and they get leaky, meaning that the fluid in them can actually start to come out, because fluid is in blood. The blood vessels typically keep all of that in. When they get relaxed, the more relaxed you get, the wetter you get. The reason it happens is because the solvent of the actual blood is actually coming out into the vagina, right? Which is the water, right? The water is the watery part of the blood vessel. So that's coming into the vagina. So note, there's not this spontaneous thing that's happening where ejaculation is coming. This is where squirting comes in, right? It's 2 different things that can happen with squirting. Typically, when a woman squirts, it is just basically her getting lubricated, and that so some women get very, 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 very lubricated. Some women get just little lubricated, right? When women get very, 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 very lubricated, where they get relaxed and they can produce these enormous amounts of lubrication and fluid, that fluid can pool in the vagina. When that fluid pools in the vagina, certain women have the ability to contract their pelvic floor muscles. Kegels, Valsalva, there are many different techniques in which you can contract the pelvic floor muscles. So when you can contract those pelvic floor muscles and you have a vagina full of fluid, that's where squirting comes from, right? So women can control. Who can control it the best? Strippers, right? Or women that continuously use their pelvic floor muscles for whatever reason that they want to, and they have control over it, and they can now control in a big synchronous gush, can move their muscles and push the fluid out of their vagina. It's almost like a puddle of water and taking a big leap and jumping in the puddle of water and having to come. Now, is that associated with orgasms? It can be, or it can't be. Some women can just squirt without having an orgasm just by contracting their vaginal floor muscles and push that fluid out. Other women, when they have orgasms, they tense and they synchronously contract their vaginal floor muscles, and that fluid that's sitting there can then be expelled. That's one method of squirting. The other one, what's the other hole? The urethra, right? So when women do get excited, they can have relaxation of the ureteric sphincter, right, which holds the urine in. That relaxes and urine can come out, and it can be expelled out in a stream. So it can be one of those two things or a combination of those two things, whether it's coming from urine, which is not all, I don't pee, I ain't pee. I'm not saying that all women pee when they squirt, but some women do. It's called, they lose control of it and it's urine, or it's the fluid that is accumulated in the vagina and they're able to push their muscles to push it out. Whether that's with an orgasm or without an orgasm is variable. But when you talk about squirting, any woman has the ability to squirt, right? When I can't squirt, I can't. If you learn how to contract your vaginal floor muscles through Kegel exercises and learn how to control your vaginal floor muscles, if you can accumulate a pool of fluid in the vagina and learn how to contract those muscles, you can expel that fluid out of vagina. Every woman has the ability to lubricate. Every woman has the ability to control those muscles. Therefore, every woman has the ability to squirt. But when you talk about squirting, it is not this spontaneous thing that happens like with ejaculation. Men, we can't control it. When it's time to release and this ejaculation happening, that is always 1000% associated with our orgasm. So when we have orgasms, there's an ejaculation. Women, not so much. People assume that squirting is always because they're having an orgasm. It's not true. Some women, again, can expel that fluid without having an orgasm, and that is squirting. So that is it. I hope this is saved so people can play this shit over and over again, because I get tired of explaining it. And then I guarantee you, I promise you, if somebody's gonna hear that, he said squirting is from Pete. I did not say that. I did not say that. I want you to listen. Don't take a soundbite. Listen to everything I just said. And I just systematically broke down what squirting is. You're not going to hear that from anywhere else. I swear to God, I've never heard that from anywhere else. Just from studying and reading and personal experience and understanding women's anatomy, I understand what squirting is. So that's why I'm explaining it. You're not going to read that anywhere. This is from Dr. Pierre Johnson and my knowledge. So take it, do what you want with it, but take and listen to the whole damn thing, please. All right, I'm done.
No, that was perfect. All right. Did you deliver your twins? And
no.
No.
I did not. I was in medical school. I wanted to, but no, the doctor at the time when I was in medical school said, just be a dad. And I'm thankful for that. If I ever have kids again, I will 1000% deliver them. Yes. But no, I did not deliver them. I think my daughter's in here somewhere while I'm talking about squirting. But
my son's in here too, because he's like, Mom, you're so pretty.
Like I had
glad he came on after the sex though.
Yeah, I'm open. I have my conversations with my child. They're better than them know than to try to figure it out somewhere else.
Oh no, I had a conversation. My son does protective over me. He don't like to hear it. So while you were also away, somebody dropped in the chat and said the acronym FTM stands for female to male. So that's what the acronym stands for.
Thank you.
Yeah, so that's why I said thank you. We learned something new.
Learned something new. Now I know. But yes, female to male. Because I always mess up the term. So a female to male. Because I can't get the terminology right. If they desire to complete that, it's no different than a male to the female, and getting rid of the penis. It's the exact same way. If you want a sexual identity transformation, you are entitled to that, and there's no doctor that should be able to tell you not. Now, again, some people bring their religious beliefs and stuff into their practice. That's not what medicine is. It's not about my beliefs. It's not about, what I feel, my opinion. It is about, serving patients.
All right. All right. So we at the end, we passed a little bit past the hour. So
Yeah.
do we want to keep going or do we want to go ahead and close out?
I mean, we can keep going if people got questions. I mean, we got, what, an hour and a half? We got like 10 minutes left?
Yeah, that'll be an hour 30 because I don't want to go too far.
Yeah, because then they'll cut it off. Yeah.
Okay. All right. So, sorry, I'm a little hoarse today for whatever reason. What causes, and I'm going to spell this, Orgasmia? Is that anorgasmia?
Orgasmia.
Is that I'm saying it right?
Anorgasmia.
Okay. What causes anorgasmia?
Nothing particularly called. I mean, there are some medications. Before I say nothing, there are some medications that can elicit anorgasmia.
Can you define what it is for?
So anorgasm, just an. Anytime you put an or a in front of something, it means lack of.
Okay.
Right. So like asystole means lack of a systolic heartbeat, but anorgasmia means lack of orgasm. So there are medications that can interfere with orgasms. There are medical conditions that can interfere with orgasms, but the number one cause of anorgasmia is lack of knowledge, right? And women that don't have orgasms really don't understand their bodies enough to have orgasms, right? So alleviating that, masturbation and understanding your body first, and knowing how to please yourself, because you can't teach anyone to please yourself without understanding. I mean, you can't teach anybody how to please you without understanding how to please yourself. So understanding your anatomy, understanding what does it for you, and not being fearful of exploring your body is important in addressing anorgasmia. But anorgasmia that are caused by medical conditions or medications are different. Anorgasmia that's just quote unquote natural, there's a cure for that, and that's understanding how to have an orgasm.
All right. And they also said if you're treating a patient with it, is it typically covered by the insurance?
Yes, anorgasmia is an ICD-10 condition. So absolutely 100% is treated. And then somebody asks, how does insurance work if you provide surgery to someone who's not in your state? So there's insurance that transcends states. Like I said, I tell people all the time, don't let your insurance dictate your care. So PPO insurances, which I don't know what the acronym for PPO is, but PPO insurances give you freedom to move around to the provider that you want to. Do your research on your insurances. And if you have a provider that's in a different state, or something that you need in a different state, upgrade your insurance, right? Be like, oh, well, it's too expensive. Well, think about it. All right, would you rather pay the $400 or $500 a month for your insurance, and then which would equate to $5,000-$6,000 for the year, to get a high level PPO insurance plan, or pay the tens of thousands of dollars for the surgery, out of pocket at one time? It makes more sense to utilize the insurance to your advantage. Every state, you can get an insurance plan that allows you to travel to different states to be able to get services. You just have to do the research and be smart, and don't feel bad, because insurance companies make billions off of our backs. Yes. Right? So when we as consumers are smart and utilize insurances to our advantage, they can't really complain. Right? You have the ability to do that. People just don't think about doing it. So if there's somebody else that preferred provider, thank you, Renita. So PPO is preferred provider option. So just utilizing a insurance that allows you to go to different states, like just do the research. They got them in every single state.
All right. Can consistent exercise cause inflammation of fibroids to where it feels like gas pains from the movement and rubbing?
No, no, it's not going to cause inflammation of your fibroids. No.
All right. How likely are you to have damage to the uterus from a DNC?
Unlikely if it's performed correctly, but you can develop something called Asherman syndrome if the DNC is performed too vigorously, meaning that the scraping of the lining of the uterus is too aggressive, too harsh. You can formulate scar tissue on the inside of the uterus and form what's called Asherman syndrome. That can happen, but you really have to be aggressive and vigorous. You know, it's difficult to do that. So just make sure you have a caring provider that knows what they're doing and that is, you know, taking care with in gentle care with your body.
All right. Last 7 minutes. Nobody wants to jump into the live.
Nobody want to jump in. Wait a minute. Who is this? Oh, somebody did. Here we go. Let's see what she got, man. I wasn't even paying attention to my little bubble.
Oh, hi.
What's happening? See, got you in. Is your name Tasha?
Yes.
How are you?
How y'all doing?
You broke up.
I'm so sorry.
It's okay.
My earbuds are on
We can hear you.
earlier.
You good?
Can you all hear me?
Yeah, we can hear you.
Yeah, I hear you.
Okay. How are you doing, ma'am?
How you doing?
I'm doing well. So I was actually coming on to ask a couple of questions. So back in 2020, I had a total thyroidectomy. And since having that total thyroidectomy, I have been experiencing a lot of heavy menstrual bleeding. I've done a series of different things as far as trying to do birth control to kind of try and regulate the heavy menstrual bleeding. I've also done a different, I would say a number of contraceptive things like pills, the shot. Now I currently, because none of those things were working, so now I have an IUD. So I got that about 90 days ago, and the bleeding has somewhat subsided, but now I'm having vaginal discharge associated with getting the IUD placed. The doctor that I saw told me if I have to get the IUD removed, the only two options that I currently have to assist me with controlling the bleeding is either a tubal ligation or hysterectomy. However, I'm 37. I'll be 38 here in the coming days. And my thing is, I feel as though I'm too young to have a hysterectomy or be forced into a tubal ligation. So what are some other things that I can do to kind of manage menstrual bleeding? And when I say heavy, I mean, like I can go into a meeting and I'm there for an hour and I'm literally soaking through a pad and a tampon within an hour. And it's typically days on end.
Great question. Thank you for sharing that. So number one, so to fill everybody in, a thyroidectomy is, you need to remember, anything with ectomy is removal. So she had her thyroid removed for whatever reason. And let me ask you this. So are your thyroid levels controlled with medication, very strictly in control now?
So no, I take a Synthroid every day, and currently it is a fluctuation because I go between hypothyroidism and hypothyroidism. So it's a fluctuation right now.
Mm-hmm.
And every like 90 days, I am getting labs drawn so that they can try and regulate my hormones in that manner.
Got you. So that's first and foremost. So first and foremost, before we can even talk about controlling your bleeding, thyroid levels have to be controlled very strictly, right? Because if you get hyper or hypothyroid, whether it be from medications or whether it be from hypo or hypothyroidism naturally, then your periods are going to be off. It doesn't matter what birth control option or hormone suppression option that you try, you're going to have to regulate your thyroid. It's their job to regulate your thyroid and get you to the second thing that you said is an IUD. So I would be extremely more patient with your IUD because it sounds like that it's working, right? So it's helping you with the bleeding, even though that there is an increased amount of discharge. 90 days is not enough time to get an assessment to truly see if that it works. With that being said, too, Because having discharge doesn't necessarily mean it's infection or anything like that. I mean, you just may be more lubricated. And I know it might be a little bit more annoying just having to wear a panty liner or what have you, but as long as it's not an infection, I wouldn't necessarily be concerned about it, especially not right now, because you are on the most effective form of treatment for uterine bleeding, which is the IUD out of all of the hormone suppressants. So, assuming you're on the progestin IUD. So, the 5-year IUD?
Yes.
Right. So that is the most effective form of treatment for your bleeding. So I would give it time. A lot of time we want to give up on it quick, but it takes 3 to 6 months for your body to adjust to that IUD and for it to really regulate. So while time, while you're giving that time, for time to but not time, but they need to get more effort into controlling your thyroid. Once you get your thyroid control with your IUD, I believe that you're significantly improved. And I agree that if you don't have large fibroids or anything else, that you don't need to correct.
Okay. And then one follow-up thing is, if there is vaginal discharge, is there any, I would say, color association I should be alarmed by if there is a change in any discharge, Dr. P?
I wouldn't say not so much color change, but more so symptoms. So if you're having irritation or itching or foul odor, I would be more so concerned about those, but not so much the color. Some women have more of a curdy or thicker discharge. Some women have more of a clear discharge. Discharge is also related to your diet and your fluid level, right? So if you're not drinking a lot of water, you're going to have a thicker, more curdier discharge. It may not be an infection, but it's a product of dehydration. So, drinking a lot of fluids, regulating your diet with a lot of, lean meats, fruits, vegetables is how to help, make sure that you have healthy discharge, because no discharge is not normal. Discharge is normal. Right? You kind of freak out about discharge, but it's not. And the color of it is, again, more so the symptoms from a point of irritation, odor. Realize too that since you're bleeding and you're having more bleeding with vaginal discharge will cause an odor, because blood and vaginal secretions will cause an odor, but it doesn't necessarily mean that it's an infection. We got to control your bleeding first, then let the IUD work, get your thyroid under control, and then try to make an assessment after that. But you're still in that phase where your body's trying to figure it out, and there are too many other variables to make a definitive statement that the IUD isn't working, because it sounds like it's actually working.
Okay, thank you. I appreciate it.
You're welcome. Thanks for
Thanks
hopping
for
on.
joining.
Thank you.
Look like we don't Listen up again.
You got another one?
No, she hung up. All right. So yeah, it's another one, but I think we're gonna cut off. It says how far are we on?
We at an hour and a half. I mean, I know we ain't got the money like Versus to be on all night, but
right. I mean, we can do it to cut off.
I ain't got Swiss money, but if it'll let you take them, if somebody wants to actually join, I say take them.
All right, that's cool. Let's try it. They ran away.
My glasses.
There you go. Hello.
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 How are you both doing?
We're doing good.
How are you?
How are you?
I'm good. That was my question about damage to the uterus. I wanted to kind of elaborate a little bit.
On what now?
I asked a question about could you have damage to the uterus from a DNC?
Mm-hmm. Okay.
And because a couple months, well, in February, I had a DNC. And I don't really know what happened during the I do remember like waking up periodically in like a lot of pain, and I was sedated, but I kept waking up. And like after I bled for almost 2 months after the DNC.
Mm-hmm.
And afterwards, I've been having like this discomfort or like this pain, and like right now I'm literally on my knees in the corner of the couch. And it's like during like a couple of days before my cycle and a couple of days after my cycle, I have like this pressure, like feeling like something's about to come out of my vagina. And it's like really painful. And I've followed up. They can't even get the speculum in. Like the last time we tried to get it done, like it was so pain, and the doctor only wants me to come like during the time where the pain is the most worst.
Mm-hmm.
And so the last time they tried, when they tried to once they was trying to get the speculum in and like open it up, the pain was so bad it literally made me throw up. So today I went for this eye. And I saw him and I asked him about like when we could follow up. And he said that he probably would have to put me on the sedation again in order to be able to do it. But I feel like ever since I had that done, like I've been having this constant pressure and sometimes even pain in my pelvic area.
Got you. So did they do an ultrasound?
No, they were supposed to do a transvaginal ultrasound,
Mm-hmm.
and he wanted to just do he wanted to just look before he did a transvaginal ultrasound.
He wanted to speculum examine look?
Yes, do a speculum exam before.
Well, I understand his desire to want to do that, but at this point, you definitely need an ultrasound. And if you have to, at this point, to like, it's not optimal, but to do an exam under anesthesia, where it's called a EUA, where you don't go under complete the subconscious, is what you do something called like a local sedation, like a MAC, so that he can examine you, look at everything that's inside, and to get a true exam to see what could possibly be the problem. That will be the next step if he wants to do an exam. But I definitely feel that you need an ultrasound to just assess, because other things that can happen, uterine perforation, meaning like a tool can go through your uterus. Typically, that's not as painful.
So what he told me afterwards, when I woke up and everything, and it was maybe like 2 or 3 days later, he was like, in my 40 years, I never had someone that shoot the speculum back out of their vagina. And I was like, what?
You're definitely in pain. I mean,
but I didn't even remember that. But I'm thinking to myself, if I am in that type of distress, I can obviously feel what's happening. I was obviously in pain during the procedure.
Are you in pain now though? Like, is it?
Yes.
It's a lot of pain right now.
Yeah, like I'm literally like on my knees on the couch.
Yeah.
And it's always like a couple of days before since the DNC, like a couple of days before my cycle, I get like this start, like not even just like cramping. It's just so much pressure that it kind of hurts. But like the last couple of days of my cycle and like a couple of days after my cycle, it's so much pressure, like sitting. I feel like I'm sitting on something, or is something trying to come out.
Yeah, you definitely. I agree. You need an exam, but you also need an ultrasound. You need both of those. So that will be the next step. If you can't tolerate an exam, then you need to do an exam under anesthesia and then also get an ultrasound.
Okay. All right. Well, thank you.
Thank you very much.
Thank you.
All right.
Thank you. If I can help in any other way,
I will, because I've been following you for a while, and I even told him he needs to check you out, because he needs to, something ain't right.
You don't.
Something ain't right. He don't. He was like, I've been doing this before he was born. Yeah. Thank you.
All right. You're welcome.
All right.
All right. Was that you? Those was the only two?
That was it. I got you.
All right. Well, yeah, since that's why I was like, let people join if they want to join. But yeah, we will stop it so we don't get kicked off.
Right.
We never know what IG gonna do with us. Hold on really quickly. I'm gonna screenshot these questions before you end it. I hearted everything I answered. And I'm gonna take a screenshot of those. It's like 4. And they will be added to the list. So if you put your question in the chat bubble, I screenshotted it and it'll be added to the list. So it'll roll over to the next month because we're still gonna do this monthly. Even when Doc P get all busy in his new practice, he's still gonna make time for the free game.
Always. Man, somebody trying to hop on here.
Uh-oh. Yeah, you missed the tag. It's at the very beginning. So when he posts this, you will get to see that. You don't even have to watch the whole thing. It's at the very beginning.
Yeah, somebody trying to hop on and ask a question.
Oh, okay, go ahead. I'm sorry.
Yeah, let me try last one.
Last one.
Oh, she declined. Okay, anyway.
Okay.
That's it.
All right.
So that's it. Thanks everybody for tuning in. Like I said, share this stuff. You know, I give all of this information because I want people to learn and people to benefit from. But if it's not, you know, the more the merrier. The more that we know about our bodies and have and understand, the better we can research our doctors. The better that we can, you know, ask questions, and ultimately the better care we get as a people. So that's what it's for. And you know, share it, please.
Yes, share it. And I will also record it and upload it to YouTube. So if you have a friend that doesn't have social media and wants to be able to watch it, it is there for you to share with. Sometimes other people that don't have any access, they still may want the information. So
yeah, and cut the squirting part out, because that was a really good explanation, if I could say so myself. That was a good explanation. I want to put that on somewhere, because like that question, I get it so much, and I just want to be like, here, listen to that.
So make an edit that just has that question.
Yeah, that's what I want. That I like, because I was like, you know, as I thought about it more, like, you know, sometimes I think about stuff and it comes out better, and it came out pretty good. So like, I want people to.
You already know. You asking me to make it. I'm gonna have to call my.
No, that's all right. Don't worry about it. Just go ahead and put it up. If they want to see it, they can do it. I'll screen record it.
No,
I'll screen record it when you put it on.
What to do? See, you didn't even give me a chance. I think I know what to do. Number one, I think I know how to edit it, and number two, I think if not, I'll just screen record that section.
All right, go ahead, go. Look at you. Look at.
Verizon employee of the month. No, I'm getting there. All right, Dr. P. Well, I appreciate you always, and until next month.
All right, everybody, y'all be safe.
Thanks everybody for joining.
All right.
All right, bye-bye.